Community Management of Acute Malnutrition, CMAM. Community-based Management of Acute Malnutrition, CMAM. This is a decentralized, community-based approach to management of acute malnutrition. Okay, its main focus is to match the nutritional need and the clinical need of a child so that the child can quickly recover. And one thing you should know about this approach is the use of ready-to-use therapeutic foods. Okay, the use of these therapeutic foods to support the child to aid quick recovery. You know that most all these malnutritions are located inside the community, especially the rural community. So you find out that malnutrition can be disastrous when the child is still having it and with other illnesses, nutritional deficiencies. So what brought about this approach of community management of acute malnutrition is that severe acute malnutrition has remained a major killer of children under 5 years of age. Okay, and restricting the treatment solely in the facility has led to limited access and coverage, including low impact. So now, after a period, evidence now suggests that most of these children in their numbers with this severe acute malnutrition in the rural community can be treated in their community without being admitted into the health facility or therapeutic feeding centers. So they can be in the community and they can now benefit from those foods that are palatable, that contain high calories and micronutrients. Okay, so that's what led to this community-based management of acute malnutrition. All right, which is a decentralized program. All right, so this approach of employing the community involves a timely detection of this severe acute malnutrition and then provision of treatment for those without medical complications with ready-to-use therapeutic foods and other nutrient-dense food at home. Okay, so that is what led to this approach of SEMA. So, and it has really yielded a very good impact. It has really yielded to a high impact. So when these children receive this treatment, especially those that are having just the acute severe malnutrition, they benefit a lot from the ready-to-use therapeutic food. And once they continue with this meal, they begin to gain weight and possibly improve. So one thing you must know about this program is this timing identification using mid-upper arm circumference. Mid-upper arm circumference is one of the is a veritable tool that is used in this program or approach. So let's look at what is severe acute malnutrition. Severe acute malnutrition is a life-threatening condition defined by a very low weight for height, okay, also defined by visible severe wasting or by the presence of nutritional edema, that is a swelling of the legs and feet. Okay, so these are the things, or this is the definition of severe acute malnutrition. It's indeed a life-threatening condition. The child's weight is so far away, or the child is having visible wasting or nutritional edema. When the legs and hands are examined, it has swollen. Okay, but it's also important to say it now that previously there have been existence of severe acute malnutrition management in the hospital setting at that point, but the only problem there was that it wasn't having enough coverage, okay, especially in areas where there is no hospital to actually or health facility to care for these children. But with the emergency of the progression of the program to community-based, then there is a clear evidence that it is actually reaching out and the impact is high. Previously, it was in the hospital and they used more of ready-to-use therapeutic food and treatment of children without having complications. Okay, so this community-based management of acute malnutrition is a strategy for identifying and treating uncomplicated severe acute malnutrition without requiring hospitalization. And according to World Health Organization, the major thing involved in this community-based management of acute malnutrition involves identifying SEMA, severe acute malnutrition, in the community by screening these children using mid-upper arm circumference tool known as the MOAC. Okay, and this followed by assessment of these children by a skilled health worker who now determine whether the child should be treated at home or in the hospital. Then followed by providing ready-to-use therapeutic food for 6 to 8 weeks, okay, and with a short course of oral medication to treat possible infections. All right, it is also important for us to state that CMAM program targets the following group of children. That is, children between the age of 6 and 59 months of age who are suffering from acute malnutrition. Okay, so these are the target population of CMAM program. Now let's look at the principles of CMAM that will help in achieving this program. One, it has 4 principles, okay, or I will say 4 components. 4 components. 1, community mobilization, because it's a community program. So community mobilization, the community needs to be involved in the program. This refers to a range of activities that build a relationship with community members. Okay, you motivate them, you go to the community, you talk to them, you inspire them, you arouse their interest so that they can participate in the project. Okay, these activities are also oriented to building capacity of the community. You now train them on early identification of this problem. You train them on early identification of the acute malnutrition, then adequate referrals and prevention. That is the first component of first principle, community mobilization. You arouse their interest and make them participate, and also build their capacity to identify acute malnutrition, to refer, and to ensure its prevention. Okay, and this includes both the community members and their faith actors who can talk to them and they listen to them. Then the next component or principle says supplementary feeding program. Supplementary feeding program. This supplementary feeding program provides take-home rations and routine basic treatment for children with moderate acute malnutrition. Moderate acute malnutrition, that is for this supplementary feeding program, without medical complication. So this second component is for children with moderate acute malnutrition without medical complication. Okay, that is when you use your shaker strip to assess the child, and from your judgment the child is moderately malnourished, the child can benefit from this supplementary feeding program. Okay, then the third component or principle is Outpatient Treatment Program, OTP. This provides ready-to-use therapeutic food and routine medical treatment for children with severe acute malnutrition without medical complication. And severe acute malnutrition, like we've defined earlier, says the child is having wasting. The child is having wasting. That is, the weight for height of that child is less than -3. That is, weight for height for that child is less than -3, or the child's mid-upper arm circumference is less than 1 millimeter. Okay, or the child has nutritional edema. Okay, so that child will have to be receiving this ready-to-use therapeutic food, with provided the child doesn't have any other complication. Then the last component, which is Stabilization Centers. This provides inpatient care for acute malnourished children with medical complications. Or those children who are at high risk for death will receive treatment for their medical complications until their condition is stabilized for 5 to 7 days. Okay, then these children are then discharged to enter the old outpatient therapeutic program for them to now start benefiting from the ready-to-use food. Okay, so these are the components of CMAM. These components come together to provide early identification through regular community level screening for acute malnutrition, referral and treatment for acute malnutrition. So if you look at these 4 components: community mobilization, sensitizing them, building their capacity to identify, refer and prevent this condition. Then move to the second level, supplementary feeding program, okay, whereby they give them take-home foods, okay, and routine basic treatment, all right, to restore these children. Then the third, which is outpatient treatment program, OTP, providing them with ready-to-use therapeutic foods which they can eat, provided the child do not have complications. Then Stabilization Center. This Stabilization Center has been existing. In fact, it is the one that has been existing, whereby it is hospital and facility based. But the other 3 components, which is outpatient therapeutic program, supplementary feeding program, community mobilization, are the ones that are added to make it community based. So this is all about CMAM. Thank you.